I see that many folks are joining us right now. We'll go ahead and get started. Welcome everyone to Cardiology Grand Rounds. It's a pleasure to have our first Grand Rounds of the year, and particularly to welcome our fellowship candidates who are joining us today. We're really pleased to have Dr. Jennifer Ho give our presentation this morning. I'll summarize Dr. Ho's 45-page CV very quickly in the interest of time, since we only have half an hour. But Dr. Ho joined our faculty in 2021 at BIDMC as Director for Cardiovascular Research. She's an Associate Professor of Medicine at Harvard Medical School, and she's built a really tremendous portfolio in clinical and translational research in the area of heart failure with preserved ejection fraction. So we look forward to hearing about her work today. Thank you, Jen, for joining us.
Thanks so much, Dr. Asnati, for the introduction. I'm really honored to kick off our first cardiology grand rounds of the academic year, and again, a warm welcome to all of the fellowship applicants. So I'm excited to talk about HFpEF, which is one of my favorite topics. I wanted to really highlight current clinical practice, but then sprinkle throughout questions that really remain very much unknowns and potentially future research projects. So we'll start off with a case. This is a 66-year-old woman with hypertension, asthma, obesity, here with worsening dyspnea on exertion. She has a normal jugular venous pressure at 6, negative HGR, negative Kussmaul's, no edema. Her BMI is 34. Her labs show an NT-proBNP, which is normal at 21, and her echo shows an LV-EDD of 44 with average wall thickness of 10, ejection fraction of 67% with no significant valve disease. And I think the questions to plant here are really, does this patient have HFpEF? What other clinical workup would we pursue, and what therapies are indicated? So we'll return to this case at the very end of the talk. This is a brief roadmap for us over the next 25 minutes or so. I want to touch on impact and scope, risk and disease susceptibility, diagnosis, and then lastly, treatment. So to set the stage, how big of a problem is HFpEF? These are data from the Framingham Heart Study in a paper published and led by Connie Tsao, one of our faculty members, that showed really HFrEF incidence in the light gray bars toward the left has been decreasing over the course of 2 decades. And by contrast, HFpEF incidence over that same time period continues to increase in both men and women. These results are really mirrored by data from the Get With the Guidelines registry from the AHA showing that the prevalence of HFpEF is also rising, such that really HFpEF is now the predominant heart failure subtype we see. Importantly, we know outcomes remain similarly poor in both heart failure subtypes, and we know that with quadruple GDMT and HFrEF, we can reduce our patients' overall all-cause mortality by up to 73%, and yet we have major strides really left to take in HFpEF. So what differentiates HFpEF and HFrEF risk? These are data pooling for large population-based cohorts, really looking into the future and seeing what at baseline predicts your risk with the hazard ratio on the x-axis. And what you can see for things like age, traditional risk factors like hypertension and diabetes, these risks are really shared with respect to who develops HFpEF and who develops HFrEF. There are really interesting, distinct differences, though, and I would say one of the ones that we've been particularly interested in are important sex differences we observe clinically as well. And the second is that really, for me, HFrEF seems much more cardiocentric when we look at risk factors like prior MI and LVH, as well as left bundle branch block, that really precede your risk of HFrEF, but not HFpEF. So let's focus on those 2 distinct features a bit more. We know clinical sex differences exist. Women outnumber men 2 to 1 for heart failure hospitalizations, 3 to 1 in some other registries for new heart failure presentations with respect to prevalence of HFpEF. The reasons for this aren't entirely clear and probably occur on multiple levels. I think first, women are more predisposed. This was a study led by Emily Lau examining cardiovascular biomarkers that differ by sex. And what you can see is that the majority do differ, and that pathways of inflammation and adiposity are really upregulated and overexpressed among women. And by contrast, pathways of fibrosis and platelet activation are upregulated in men. And so you can see, if we think really about inflammation and adiposity as 2 major risk factors for HFpEF, you can see how this can lead to major sex differences. We also know that in response to traditional cardiovascular risk factors, men and women remodel very differently. For example, in response to hypertension, women are much more likely to develop concentric LVH compared with men. And then lastly, we're beginning to scratch the surface really on understanding female-specific factors. We recently showed that infertility specifically predisposes women to HFpEF and not HFrEF. And other groups have looked at preeclampsia and the presence of hypertensive disorders of pregnancy and their strong associations with HFpEF as well. So much to learn here, I would say. The other thing I'll highlight is sort of thinking extra cardiac about risk factors. It's important to recognize the evolution of obesity and cardiometabolic disease as really one of the main and central drivers of HFpEF risk now. These are data looking at men and women with and without obesity. And we showed really that obesity is a much stronger risk factor for development of HFpEF compared with HFrEF. And more importantly, that women shown in the solid red compared with men shown in the solid blue with obesity are at greater susceptibility. These data are also mirrored by data published from Ambarish Pandey at UT Southwestern showing that physical inactivity is, again, specifically associated with HFpEF, but not HFrEF. So I think this highlights really an enormous opportunity for us to think about disease prevention in light of evolving approaches to obesity. So how do we put together how we think about disease risk? I've highlighted the important role of obesity, insulin resistance, and cardiometabolic disease. We know there are sex differences that probably are pervasive and have multi-level influences on risk of HFpEF. We and many others have also looked at contributions of arterial stiffness, hypertension, and many other multi-organ system dysfunctions that lead to ultimately HFpEF. And so the current pathobiologic paradigm is really that it's these systemic comorbidities that induce a systemic inflammatory state and multiple abnormalities across many organs, including the heart, that then lead to HFpEF. And so with this pathobiologic paradigm, it's not a surprise that HFpEF can be quite heterogeneous phenotypically. And I would say that is, I think, at the crux of what has made HFpEF really challenging to diagnose. So to illustrate this, I've pulled HFpEF definitions for various society guidelines, as well as major HFpEF clinical trials. In the blue is the new universal definition of heart failure that was published in 2021. And this really mirrors the latest ACC/AHA guidelines. To top it off, how we understand heart failure and what drives healthcare policy are diagnoses of heart failure based on billing codes or ICD codes that don't incorporate these criteria at all, shown in the yellow. And so you can see this is really all over the place. We insist on symptoms, some signs. When it comes to more objective criteria, depending on which study you're looking at, echo criteria are really variably used, as are prior cardiovascular admissions and the presence of elevated natriuretic peptides. And so to further sort of dissect this down, why is this so problematic if we can't agree on who even gets labeled as having HFpEF and who doesn't? We took a really neat approach. This was a study of 461 patients with dyspnea and a preserved ejection fraction. And what was unique about this cohort is that they had deep phenotyping with clinical biomarker and exercise testing. And we simply applied these different definitions to the same sample. So you can see when we look at society definitions of HFpEF, we end up with sort of widely disparate classifications of HFpEF. By ACC/AHA, the majority of individuals in this sample would have been classified. By HFSA, the minority. If we apply clinical trial criteria and see who might have been enrolled in a clinical trial, you can see, again, non-overlapping Venn diagrams in who we might have included in major HFpEF clinical trials. And then when we go back to a very physiologic definition of HFpEF, including the presence of elevated left ventricular filling pressures, either at rest or with exercise, we can see that about half of this sample met those criteria. Not only do we end up with really variable sample sizes in who gets labeled, depending on that sample, we also variably enrich for who has bad outcomes. And so you can see in the top this would be with the ACC-AJ classification. At the bottom, this would be with the HFSA classification. So in this context, we asked a simple question, and that was whether machine learning approaches could possibly get us to a more precise definition of HFpEF. I've been lucky over the past 3 years or so to work with the Machine Learning for Health group at the Broad Institute, and this has been really a unique collaboration because it's brought together data scientists, engineers with clinicians to learn from each other. And so this was initially work led by Sean Kershid and the whole team, where we constructed a real-world cohort based on individuals receiving regular ambulatory care at MGB. And this cohort really enabled this next study, where we asked whether natural language processing might help refine incident heart failure case definitions. And so I again already alluded to the fact that currently the way we understand health outcomes in large administrative data sets are based on ICD code-based diagnoses for heart failure. And yet we know misclassification may be a problem, especially for a complex disease like heart failure. And so our hypothesis was really that natural language processing can accurately and scalably adjudicate heart failure hospitalizations. So what did we find? If you look at all of the ICD codes that were coded for heart failure in the primary or secondary position, and you then compare it against a gold standard clinician adjudicated heart failure label, you can see that just about a third actually were true cases of heart failure. This is pretty dismal, I would say. If we move that ICD code to the primary diagnosis position only, we improve that to about 60% of true positives. And you can see that our NLP model really enhances accuracy of this with 80% of the cases correctly classified. So we hope in the future this work will help us better understand disease trajectory in the real world. And I think lots more work really to do here. So how do we really think about on a clinical basis diagnosis of heart failure? I mean, what are the tools at our disposal? The use of natriuretic peptides for heart failure diagnosis is of course a class 1 recommendation. Among patients with dyspnea, typically we use a cut point of 125. For ambulatory patients, this is higher among hospitalized individuals. I'll say that there are limitations to natriuretic peptide testing. We know that about a third of patients with HFpEF have low natriuretic peptides or natriuretic peptide deficiency. This is particularly pronounced among patients with obesity and insulin resistance, but there may be other factors that contribute to this. We, of course, also use echocardiography as the cornerstone of diagnosis. We want to see a preserved ejection fraction and some evidence of either abnormal cardiac structure or function. What I think is really interesting is that Paragon-HF, which was the RNA trial that enrolled HFpEF patients, in their echocardiographic sub-study, up to a third of patients with true HFpEF had no echo abnormalities. We also know from other studies that the sort of best echo measure, which is the E/E' ratio, correlates with directly measured LV filling pressures with sort of a modest correlation coefficient with an R of 0.6 or so. And so I think natriuretic peptide and echo are really first-tier studies for diagnosis. When these are not sufficient or when diagnosis is still unclear, then I would say provocative testing should be considered. And exercise testing is particularly important. This is really illustrated nicely in the study on the right. This is data from Barry Borlaug's group at Mayo. You can see that patients with HFpEF and hypertension really can start with normal filling pressures at rest, but really with peak exercise, these two curves separate, and patients with HFpEF have really this enormous rise in pulmonary capillary wedge pressure with exercise provocation, leading to a diagnosis that's really unmasked with exercise testing. And so what do we deem abnormal? Invasive hemodynamic testing really seems to be currently the gold standard in which to define this. In the supine position, we can typically call abnormal a rest wedge pressure greater or equal to 15, or an absolute exercise wedge pressure greater or equal to 25. In the upright position, we and others have studied really indexing your flow by flow. And so we look at something called the wedge by cardiac output slope. And if the slope is steep, you're sort of paying a bigger pressure increment for each increase in cardiac output flow through the system. And so that is sort of deemed abnormal diastolic reserve, if you will. There are other provocative maneuvers that people have looked at, including passive leg raise and volume challenge. So I think that the takeaway here is that sometimes people at rest may appear normal, but with some provocative maneuver may actually display really abnormal cardiopulmonary physiology indicative of HFpEF. So to emphasize the central role of exercise testing, I wanted to highlight some recent work led by Leah Koziarkowski, who's one of our third-year fellows. She examined a total of 78 research volunteers who were really people who were had obesity and dyspnea, but otherwise were not known to have HFpEF or cardiovascular disease. And these individuals underwent echophenotyping and in appropriate cases also went on to cardiopulmonary exercise testing with invasive hemodynamic monitoring. And these results were really remarkable. So at least a third of these individuals who were research volunteers with no diagnosis of HFpEF actually met hemodynamic criteria on CPET. I think what these data illustrate is that HFpEF is probably vastly underdiagnosed among patients with obesity. What's also interesting is that there was really no difference in NT-proBNP values or any of the echo parameters, including E over E prime ratio, between those that met HFpEF criteria and those that did not. So I think there's still a lot to learn in terms of who has HFpEF in the community. Are we really missing people? And as our therapies are evolving, is that really a missed opportunity for us to think about disease treatment? So how do we put all these pieces together? This is a practical approach we put together some time ago, really incorporating all of our diagnostic tools at our disposal. So first, HFpEF very much remains a clinical diagnosis. If you have a patient with evidence of rest congestion by clinical exam and LVEF is preserved, then you can be comfortable and make a diagnosis of HFpEF. An important early branch point is consideration of secondary causes of HFpEF. And there we really have to be very careful to think about a workup to rule out primary cardiomyopathies, including, for example, cardiac amyloidosis or other restrictive cardiomyopathies, which may entail entirely specific other therapies that are separate from what our focus is for today's discussion. I would say where HFpEF diagnosis is much more challenging is among individuals where evidence of rest congestion is absent and the main symptom is exercise intolerance. And here we can use non-invasive tools to risk stratify, including echo, natriuretic peptides, assessment of overall functional capacity. This is also where some of the evolving diagnostic algorithms may come in. I didn't mention them in my talk, but many of you have probably heard there are these risk scores, including the H2FPEF that was developed by Mayo and the HFpEF algorithm developed by the ESC that help us sort of risk stratify into low, intermediate, and high risk. And then I would say the importance of advanced testing where the diagnosis remains unclear cannot be understated. This is where I think sort of the gold standard invasive hemodynamic testing comes in, as well as provocative maneuvers, including the importance of exercise. So in the last 10 minutes or so, let's turn finally to medical therapies of HFpEF. These are our latest ACC/AHA heart failure guidelines. We'll go through these just briefly. As you can see here, loop diuretics to treat congestion remain the only class 1 indication currently to treat HFpEF. There are 2 new classes of medications that obviously have evolved over the last few years. The first is the use of SGLT2 inhibitors in the treatment of HFpEF. The 2 landmark trials, of course, were Emperor Preserved and Deliver. These studies really showed that the benefit of SGLT2 inhibition in HFpEF was irrespective of diabetes. And I would note that recently the updated ESC heart failure guidelines actually increased their level of recommendation to a class 1, and I suspect that our own guidelines will follow suit shortly. The consideration for SGLT2 inhibitor use in HFpEF patients is similar to HFrEF, again, contraindicated in type 1 diabetes and at low eGFR. The other class of medications that was sort of new to these guidelines was the use of ARNI in the setting of HFpEF, and the pivotal trial here was Paragon HF, which studied angiotensin receptor neprilysin inhibitor versus valsartan. What I thought was really interesting about Paragon-HF is that there were subgroup analyses. The overall trial was neutral with a P of 0.06, but subgroup analyses showed a potential benefit in people below versus above median ejection fraction, and benefit in women compared with men. And so currently in clinical practice, I think what expert panels have sort of recommended is that these agents should be considered at patients with LV ejection fraction at the lower end of the spectrum. These are the data that really illustrate this super interesting interaction with LV ejection fraction. These are pooled data from the ARNI trials shown on the left, plotting LV ejection fraction on the x-axis and the rate ratio for ARNI versus ARB or ACE on the y-axis. You can see that the benefit of ARNI is really dependent on LV ejection fraction, and that this is different for men and women. So in men shown in the blue, you can see that that benefit crosses neutral at around an ejection fraction of 55%. And the benefit crosses the neutral line in women around an EF of 65%. This is the analogous result for SGLT2 inhibitors on the right. And you can see that here, by contrast, the treatment effect seems entirely independent of LV ejection fraction. So what do we do in practice now? This is the Northwestern algorithm we recently published in a JACC expert review. This isn't meant to be read, but more for your reference. What I did want to point out and what I like about this algorithm is that really what this advocates for is for SGLT2 inhibitor use broadly across patients with HFpEF. In the setting of volume overload, I like to use mineralocorticoid receptor antagonists up front to deal with some of the volume overload with additional loop diuretics as needed. And then the use of ARNI is really reserved for patients with persistent symptoms, if you have blood pressure room, or if you have patients with LV ejection fraction in the mid-range or lower end of normal, or in the context of multiple admissions. Just as important as sort of knowing what to do is also knowing what not to do. And so in the guidelines, we know that the routine use of nitrates or PDE5 inhibitors is really ineffective to improve quality of life. Some of the other things I want to highlight, beta blockers may often worsen chronotropic incompetence, which we know is a major contributor to exercise intolerance among patients with HFpEF. And so often we'll take a careful look at beta blocker use. And in the absence of other compelling indications, we may actually down titrate or stop beta blockers altogether in symptomatic patients. We know PA hemodynamic monitoring devices can be considered as a class 2B. The trials that really looked at PA hemodynamic monitoring were looking at acute heart failure and included both HFpEF and HFrEF patients. And so these are sort of what we have at present. I would say that we still, despite these major advances, have a long way to go. For example, these are the primary results from the DELIVER trial, and you can see that treatment with dapagliflozin really improves your risk of the primary outcome. Yet what we're left with is a massive residual risk, even in those individuals. 20% risk of heart failure hospitalization or CVD death over 3 years is not a number that we want to be living with. And so where do we go next? I would say the current approach in the guidelines is really very much a one-size-fits-all GDMT approach, which I am a fan of and we're instituting clinically. I think there's a lot of excitement about thinking more closely about phenotype-guided precision approaches that really specifically target obesity, inflammation, metabolic disease, and inactivity. And so here are just some of the exciting trials to keep your eye out for. There are trials around non-steroidal mineralocorticoid receptor antagonists, including Spirit, HFpEF, Spirit, and Figaro. We know GLP-1 receptor agonists have recently been shown to really potentially have major benefits in terms of quality of life. This was the trial STEP-HFpEF published recently and presented at ESC, where treatment with semaglutide really showed a sustained weight loss as well as improved quality of life and exercise function. And so I think those two are sort of, from a therapeutic perspective, really major classes of medications to watch out for. One other trial that I'm really excited to see is we know that cardiac rehab currently is not reimbursed by CMS for patients with HFpEF, and yet we know there are data showing that exercise training can benefit with respect to functional capacity and quality of life. And so the first trial looking and powered to look at outcomes called Rehab HFpEF is being run by Delane Kitzman's group at Wake Forest. And so this, I think, is going to be a pivotal trial to think about exercise training and cardiac rehab in this patient population as well. And then I'll leave you with a teaser of work that's about to come out from our lab. We've been really interested in how obesity may incite systemic inflammation and whether there are specific pathways that we can target on to think about HFpEF prevention. One of the large classes of molecules that's super interesting to think about are termed eicosanoids. These are bioactive lipids that govern initiation of pro and anti-inflammatory activity. And so we, in an initial study, showed that specific eicosanoids, including prostaglandins and linoleic acid derivatives, were associated with HFpEF. And helped us sort of tease out cardiopulmonary reserve across multiple organ systems. And more importantly, some of these bioactive lipids also appear to mediate the association of obesity with HFpEF. For example, this particular metabolite 898-EPETE, which is an EPA derivative, mediates up to 21% of the effect of BMI on HFpEF. And these metabolites also seem to predict your future risk of HFpEF. So I think, again, these things, these metabolites seem to be of biological importance. And I think the outstanding question is whether or not we can sort of tailor therapies in the future to target inflammation. So to return to our case, this was really a patient who presents with unclear etiology of dyspnea on exertion with no evidence of congestion at rest and a normal natriuretic peptide level. She underwent a pretty extensive workup, including lung function testing, a resting right heart cath, and cardiopulmonary exercise testing. And this really was diagnostic of abnormal diastolic reserve. She started with a normal wedge pressure that really rose quite dramatically with exercise. And so the diagnosis here is exercise HFpEF or exercise-induced left atrial hypertension. These are often really challenging cases to treat. She was started on low-dose diuretics and SGLT2 inhibitor and spironolactone. And then with respect to weight loss was recommended for lifestyle changes. And I think in light of STEP HFpEF should really be considered for GLP-1 receptor agonist as well. So to recap, we know the global burden of HFpEF is increasing in both incidence and prevalence. We have persistently poor outcomes and likely vastly under-recognized individuals, especially those with obesity. With respect to thinking about disease susceptibility, we know there are overlapping risk factors with HFrEF, but there is a female predominance in patients with HFpEF, and again, central role of obesity and associated cardiometabolic disease. With respect to diagnosis of HFpEF, I think it's really important to keep in mind secondary causes of HFpEF or mimickers with a careful workup. We know clinical exam, natriuretic peptide testing, and echo are really first here, and then considering provocative testing and the importance of CPET for advanced testing in those cases that remain diagnostically unclear. The medical management has evolved. I would say that SGLT2 inhibitors should be considered broadly, and future trials really focused on GLP-1 receptor agonists, MRA, and cardiac rehab are forthcoming. So I'll stop here. I want to thank really the heart failure section for being my clinical home, all of my lab members and collaborators who sort of make this fun and enable all of the work that I highlighted here. And I'll stop there. Thank you so much.
Thank you so much, Dr. Ho. That was wonderful. We have one question that came in the chat. I think we'll probably just take one question in the interest of time. Oh, actually, we have two, so we'll take both of those. The first comes from Dr. Lauren Feinberg, who said, great presentation, Jen. Why do you think recurrent GLP-1RA HFpEF trials looked at softer outcomes like quality of life and weight loss in this patient population rather than harder CV outcomes? Seems to have lessened the strength and implications of the study in this patient population.
Yeah, it's a great question. I think there are many I feel like the more you know, the more you realize you don't know. I think that large outcome studies hopefully will be forthcoming. I do think if we compare sort of the magnitude of effect with respect to like increase in 6-minute walk distance or improvement in KCCQ, compared with all of the other HFpEF studies, STEP HFpEF really blows those studies out of the water. So I do think there's a strong argument to be made to sort of think about use upfront. But I agree with you, Lauren, that we do need more data over the long term as well.
Thank you. And one final question from Dr. Warren Manning. Wonderful presentation. Are there any data on genetic predisposition to HFpEF?
Great question. These data have been really challenging to come by. There have been large GWAS of heart failure overall, with the largest consortium called Hermes that identified obviously genetic predisposition to HFpEF as a complex trait. That study did not parse outcomes into PEF and REF. So this is something that I'm actually super interested in, and I think this will evolve quickly.
All right. Well, thank you very much, Dr. Ho. It was a wonderful presentation. We'll let everyone get to interviews.
Thank you.
Bye, everyone.